There's audience on this side as well. Right.
Make it full screen. Okay. Video kan. Screen में सब चला ना. ini betul. Tapi क्या करना है? स्टॉप कर. हाँ मैं मीटिंग किया है. न्यूज़ किया. नहीं.
Post करो.
हाँ. मीटिंग किया है. तो नहीं.
कॉपी करें नहीं.
कॉपी करें. हाँ कॉपी कर लगा.
कॉपी कर. मेरे बोला ना. Convenient. So hope you are. Thank you very much, Dr. Dinesh, for those kind words of introduction. Good afternoon, everyone. Due to the technical errors, we'll have to shift. We had to shift to this auditorium. I hope the things would go on nicely. Now, today I'm going to talk about a few basic things about autoimmune inflammatory polyarthritis. I'll be giving an overview, and this presentation is not mainly about the guidelines or pathophysiological things. I would try to give some of the most important concepts which we come across in managing patients with inflammatory arthritis. So my aim is to sort of demystify these diagnostic dilemmas and the management principles. So this is the outline of my presentation. I'll be talking about what inflammatory arthritis is, and then briefly go through the clinical phases of rheumatoid arthritis, and also we talk about management principles or the guidelines in a simplified way, and finally we'll deal with some common pitfalls. So inflammatory arthritis, what is inflammatory arthritis? So inflammatory polyarthritis. So first of all, we need to clarify what inflammatory joint symptoms are. So it's what you mean by inflammatory joint symptoms are, it's non-traumatic or non-bony pain and swelling, which is associated with significant early morning or inactivity stiffness. Which I mean by a significant thing is it would be lasting for more than 30 minutes and the symptoms relieves with activity. So the simplest way to explain this is, we all know what inflammation is. There are 5 cardinal features of inflammation. What happens is when there's a joint inflammation, with the inflammatory process going on, there would be joint fluid accumulating in the synovial space, leading to these symptoms. That is why when you start activities, these or the inflammatory fluid gets reabsorbed into the circulation, and therefore the symptoms gets relieved. So this is the basis of inflammatory symptoms. Now we all ask about the morning stiffness. Now point to point is, if we ask about the morning stiffness from a person who's working at night, he would say no. So if somebody is sleeping at the daytime, so obviously he would be developing the symptoms after the period of inactivity. So that patient would say that he doesn't have a morning stiffness, but basically inactivity stiffness. So that is the point that we need to always clarify in our history. And the inflammatory joint symptoms may be associated with raised inflammatory markers. And it's not a must that we always don't see raised inflammatory markers in inflammatory arthritis. For example, psoriatic arthritis, we come across normal ESR and CRP. Then the wording of autoimmunity. What is meant by autoimmunity is immune system generally reacts against body's own normal components, producing a disease or functional status. So if the basis for the inflammatory polyarthritis is the autoimmunity, you call it the autoimmune inflammatory polyarthritis. Obviously, polyarthritis is when there are more than 5 joints involved. Examples for polyarthritis includes inflammatory polyarthritis, rheumatoid arthritis, psoriatic arthritis, and we all know about peripheral spondyloarthritis and connective tissue disease associated arthritis. And even in crystal arthritis like gout, people might come up with polyarthritis, but remember, it's not of autoimmune basis. How is Sorry for the interruption. So in the initial statement, I said bone is swelling, and what we need to differentiate is we need to differentiate bone is swelling with the boggy swelling. where do we see bony swelling is, we generally see the bony swellings in osteoarthritis. So the first picture here, this area, you would see a bony swelling. So this is a typical Heberden nodes in nodal osteoarthritis. But in contrast, what you find in inflammatory arthritis is a boggy swelling because of the synovial thickening. Here, I hope that you can appreciate this swelling. So this part you would be seeing a bit of a swelling. This is if you touch it, it's a boggy swelling kind of thing. So this is what you find in inflammatory arthritis, not this kind of a swelling. These are the ones which you find in nodal osteoarthritis and degenerative arthritis. So this is a typical picture of a rheumatoid hand. Now, if we go on, the rheumatoid arthritis is the commonest autoimmune inflammatory arthritis. So my presentation would mainly based on the management principles of rheumatoid arthritis. Because of the time constraints, I would not have time to talk about the others in detail. So if we see the first picture here, you would be seeing the typical rheumatoid changes, which are Boutonier's deformity. Sort of, we don't see much of a Z thumb here. And this is what we call the swan neck deformity, where the proximal interphalangeal is extended and the distal interphalangeal is flexed. And also, generally in rheumatoids, there would be an ulnar deviation of the fingers with the dorsal subluxation or the ulnar subluxation. So this pattern, just so this, if I can still remember where I presented my first case of rheumatoid arthritis when I was a fourth year medical student, roughly in around 2005, and I had to present this case to Dr. Sarath Gamini De Silva, who's a senior consultant physician. And I was so happy at the end of the presentation or the case history, because I was able to tick all the extra-articular manifestations and kind of the textbook stuff at the end of the case history, because that patient almost had all. But later on, one decade later, I understood when I was presenting the cases to, when I was a registrar to Dr. Dumindu Munidasa, that over that decade, things have changed, and dramatically, we don't see much of these deformities by that time. Or nowadays, we hardly see the rheumatoid deformities. So what we would come across is something like this, very subtle deformities, and you are not sure whether this is a normal hand or a rheumatoid hand. By experience, if you look at this, there's subtle MCP swelling. With the history, you might be, and the investigations, you may come across, you may establish a diagnosis, but it's very difficult generally to see this kind of thing and come to a conclusion. So this is what you mostly come across nowadays. Why you don't see this is because of few things. We nowadays are sort of nipping it in the bud now. What you mean is, you don't allow the tree to grow and you start picking it up right at the younger stages, and you won't allow it to progress. So that is where you don't see much of deformities nowadays. So how has this change occurred? There are two things which has led to this change. One is prompt diagnosis at early stages. Under the prompt diagnosis, there are things. One thing, we have understood the clinical progression more. The second thing is, there is revision of criteria, and there is the ancillary investigations such as radiological investigations and autoantibodies, which helps in the diagnosis of inflammatory arthritis or particularly rheumatoid arthritis. The second thing which has led to this situation is commencement of DMARDs or disease modifying drugs early in the disease process. So we have time to time, these guidelines are getting updated, and which I would talk about in briefly in later on during the presentation. So the most important thing is to identify the clinical phases of rheumatoid arthritis. So there are healthy individuals who are susceptible with genetic risk factors and environmental risk and systemic autoimmunity to develop rheumatoid arthritis. Initial phase, they won't come up with rheumatoid hands or rheumatoid arthritis. What I mean is, they won't come with pain and swelling of small joints of hands. What they would come across is mainly with the arthralgia. What you mean by arthralgia is only the pain in the joints without any clinical significant stiffness or swelling. Now, this is the crucial point for a general practitioner or MO, because at this point we need to pick these people up. How are we going to pick these people? Are we going to refer everyone to rheumatology or the internal medicine services? No. There are people with a clinically significant arthralgia. So this is a guideline which recently came up to differentiate arthralgia from clinically significant arthralgia, who are at risk of developing rheumatoid arthritis. So in the history, if a patient comes with arthralgia of a short duration, particularly affecting the MCP joints, metaphalangeal joints, with the duration of stiffness more than 60 minutes, as I mentioned, with the inflammatory component, having the symptoms early in the morning, and there's a family history of rheumatoid arthritis, those people are at high risk of progressing into RA. These are the people in the OPD or somewhere you need to catch up and refer to the rheumatologist or internal medicine specialist early. And whoever comes like this needs a long-term follow-up to see if they develop features of inflammatory arthritis subsequently. Later on, the third phase is where they would be having early undifferentiated kind of arthritis. You know what, there are a few joints, joint involvement, but they does not fit onto a rheumatoid kind of pattern. And ultimately, they develop rheumatoid arthritis. So the purpose of our knowing the clinical phases of RA is we need to catch people at these two stages. Refer to appropriate care at that point. So there are revisions of guidelines to catch these early populations. And also, we can advise the patients. This is a leaflet which readily circulates in NHS, where you have to look for 3 S's. It's very simple: stiffness, swelling, and with the MCP squeeze test, metaphalangeal squeeze test. And if it is positive, you refer to a specialist care. That, of course, you all can do even in your general practice or wherever. So the other landmark thing is, when we were medical students, so what we learned was this 1987 revised ACR criteria for RA. If we go through that, if you look at number 7 and so on, it would say radiological changes. And there is rheumatoid nodules and so on. These criteria, you don't need a specialist or a medical officer to diagnose rheumatoid arthritis using this criteria. Even a general layperson can most of the time the diagnosis if we use this criteria, because you are picking the patients at the end of the or once you have developed rheumatoid arthritis. But in contrast, this classification of criteria was changed in 2000s. Yeah, now we are looking at the number of joints, serological status, the duration, and acute phase proteins. Or with this, we are catching up more and more people. So out here, you need at least 6 points. This is a cumulative score that you get to diagnose a definitive rheumatoid arthritis. And in addition to the development of these criteria, there are 2 things which are assisting in our diagnosis. One thing is autoantibodies. What we were doing all this time is a rheumatoid factor. But rheumatoid factor is highly non-specific, and it would be found in general population as well. And it would be found in about 15 to 20% of the general population. So if just because you have a rheumatoid factor positivity, it doesn't mean that you are having rheumatoid arthritis. So in contrast, anti-CCP is more specific, and it could be the specificity is about 96%, and the presence would not only assist in the diagnosis, it also tells you about the prognosis. Because if a patient has a positive anti-CCP, there is high chances that he might develop a severe form of disease, and he might also develop extra-articular manifestations. And it also correlates with joint erosions. But mind you, this is not a must. I haven't performed anti-CCP. I have only performed one anti-CCP in Sri Lankan setup. Because if you take a good history and take a good examination, and you might not need the anti-CCP, because remember, this cost about 6,000 to 7,000 rupees. Whereas a rheumatoid factor would cost about less than 1,000. So you might not be able to judiciously request for anti-CCP antibodies. So most important thing is the inflammatory joint symptoms, possibly the clinical examination. And if that is, if I have a doubt, what I do is, I have 2 excellent radiological colleagues at Markle. So I would go for an ultrasound scan to detect clinically detectable cyanosis. So if that there is clinically detectable or radiologically detectable cyanosis, that again has to be done with in selected cases. Otherwise, they'll be overburdened. In that case, we would be starting the treatment early rather than going for anti-CCP and all. Because this would, I believe this would not cost us much more than 2,000 to 3,000 rupees. On the other hand, this is a typical radiological investigation that we see in rheumatoid or X-ray finding we see in rheumatoid arthritis, where there would be a carpal crowding with carpal bone erosions, and also you would see MCP erosions here, and this is the typical site of rheumatoid erosions. That is the pericardicular bone. In case of a distal arthritis or gout, you will be seen more on the juxta-articular region than the periarticular region. But these are later stages. You can still get an idea or come to a diagnosis with X-ray at early stages if there's periarticular osteopenia, soft tissue swelling. And as I mentioned, ultrasound is a useful investigation. And because of this thing, now there are recommendations coming up on use of imaging in rheumatoid arthritis. Because the summary of this is that you can use ultrasound, MRI in radiological diagnosis. In fact, it's superior to the clinical examination alone. and it can predict or make a sort. If you have undifferentiated arthritis, you can sort of assess the progress, and also in the context that if you have treated treatment, you can assess the progress with serial ultrasound scans, which is not done in the Sri Lankan setup because of the availability of limited resources. So the third section of this presentation, the management principles. I'll be talking about the management principles in a simplified way. So inflammatory polyarthritis is a kind of a like a seesaw. On this side, there is so there's imbalance where there's increased joint symptoms, high disease activity, restricted ADL, or presence of extraarticular manifestation. What you need to do is in the treatment, you have to push it up or by putting the weight on the other side. So controlling of symptoms and lifestyle modifications. One important lifestyle modification in rheumatoid arthritis or inflammatory arthritis is stopping cessation of smoking, therapy assessment, and the addressing of control of extraarticular manifestation, in particularly interstitial lung disease. All patients with inflammatory polyarthritis are at risk of cardiovascular disease due to the disease itself, or might be related to the medications that we give. And also they are at risk of developing early osteoporosis. So this is the basic nutshell or the concept of treating inflammatory arthritis. So in this presentation, I'll be mainly dealing with control of symptoms to symptoms control or disease activity control. So these are the two guidelines which we rheumatologists refer to. The 29 updated guideline on RA management, and also 2016 guideline on management of early arthritis. The salient point in managing early arthritis is, or in the both guidelines is, it says treatment with synthetic DMARDs or disease modifying treatment should be started as soon as the diagnosis of rheumatoid arthritis is made. Why you need to start is because any delay in the start of disease modifying treatment in patients with RA may lead to worse outcome in comparison with early state of early commencement of treatment. And this is the most important point in that guideline. Patient at risk of persistent arthritis should be started on DMARDs as early as possible within 3 months, even if they do not fulfill the classification criteria for rheumatological disease. So what it means is you don't need the patient to fulfill the criteria of rheumatoid arthritis. If there's inflammatory joint symptoms and you demonstrate a persistent synovitis, you start on the treatment early. And the second point is a very valid point. Among DMARDs, methotrexate is considered to be the anchor drug, unless contraindicated, and it should be the first treatment strategy in patients with persistent disease. So starting with this three months period is we call a window period. Why we call it window period is this is sort of a window of opportunity, where if you start on the treatment at this point, you would prevent the joint damage, the bone erosions, and sometimes you might be able to reverse the disease itself. But important thing to remember is, even though you start DMARDs early, disease modifying treatment will take some time to act. For example, if you start on methotrexate, it would take at least 6 months to act. For sulfasalazine, it could take about 2 to 3 months. Leflunomide, it could take about 4 weeks. Now, the second point is, when you start treatment, it should be a targeted treatment rather than going on blindly escalating or increasing the disease modifying treatment. How you decide on the treatment target is, there are established targets. If you find a new arthritis, disease remission. If there's a chronic arthritis, you would not aim for a disease remission. You would be aiming for a low disease activity. This is similar to kind of a management of diabetes, where you would be targeting for very strict diabetes control in a young patient. But if there are comorbidities and other things, you would not be targeting at a stringent control of or HbA1c control. So what we commonly use is the DAS28 scoring system, and there's an online scoring system. It's very simple. It's a composite score where we would look at the tender joints, swollen joints, patient pain score, and CRPO ESR. If the composite score is less than 2.8, call it low disease activity. More than 5.1, high disease activity. So the treatment wise, you target at this point, low or remission. Mine is less than 2.6 is the remission. 3.2 to 2.6 is the low disease activity. So place of steroids. Now, as I mentioned earlier, remember all these DMARDs would take about at least 1 or 2 months to act. If somebody comes to you and you prescribe methotrexate and ask the patient to wait for 6 weeks, it's not rational. I mean, the patient's symptoms are there, so he would obviously default the treatment and go on for other treatment options. So in that case, what does we usually use steroids as a bridging method. What you mean by the bridging method is, let's say there's a river. You have to cross the river, and in that case, the option is, until you make you don't have a bridge, until you make a permanent structure, what you would do is you temporarily get a bridge and do something like this. So this is the permanent structure, and you will be just putting a bridge and reach the destination until the things get stabilized from this side. Hope you understood what I'm saying. So until you might need to control or continue steroids for at least sometimes maybe 2 to 3 months until the proper structure, that is disease modifying drugs, starts on acting. So what the basic concept is, you start with a higher dose of steroid. Generally, a 15 milligram is enough for any inflammatory arthritis. 15 milligrams of prednisolone per day. Slowly or taper, reduce it slowly while you escalate your DMARDs. Once disease modifying drugs start acting fully, you may be able to take off the steroid. So this process might take three months or so, and the guidelines allow you to treat with steroids for so some points about steroids. Which steroid you can use? Prednisolone or methylprednisolone. According to the studies, there is no difference between prednisolone or methylprednisolone in controlling inflammatory arthritis, but with prednisolone, there is some risk of high chances of developing side effects more than methylprednisolone. Dose, generally, methylprednisolone, the maximum dose would be 15 milligram. Sorry, for prednisolone. For methylprednisolone, it would be about 12. For steroids like deflazacort, it would be about 18. For how long? Generally, we tend to continue steroids normalizes, and if there is no contraindication, and until the DMARD start acting. That could take about 2 to 3 months. So you start off with 50 and slowly taper off over the next couple of months. Then the question of this, are divided dose effective, and can we prescribe a nocte dose? This doesn't come in the guidelines, but in clinical practice, you give a divided dose. Let's say you need to give prednisolone 15, you give 10 in the morning, 5 in the 5 in the night. Why you give 5 in the night is, as I mentioned earlier, inflammatory symptoms are more in the morning. If you give a bit of a nighttime dose, you act on those inflammatory symptoms. So nicely they would act in the night, and the patient wouldn't feel much of the stiffness in the morning. The question, are intramuscular injections effective? If they do, they are really effective. In a NHS system, they give 120 milligrams of depometron and ask the patient to come up with the investigations in 1 month's time. But in our setup, the problem is, I find it difficult to give IM depometron injections due to 2 reasons. One is, this is a buttock injections, and so people don't like much of buttock injections. And when I just came from my foreign training, I started practicing this in New and it was so effective. And patients thought there's a permanent cure, and they stopped their DMARDs and they defaulted. And came up 3 months later with a complete clear of disease. So if you are giving intramuscular injections, you need to advise them and say that this is not a permanent cure. This is a kind of a temporary thing, which we all give just to act as a sort of again as a bridging method until the proper medication works. And the last thing is, newer steroids are coming up, such as deflazacort, and they are effective in a way. They have the same efficacy, but with a low side effect profile. I generally use the deflazacort in patients with poor glycemic control, where you need to start on steroids. But this again is not available in government sector. A word about NSH. Obviously, we all have to use NSH if there are no contraindication, but should be used at the minimum effective dose for the shortest time possible, after evaluation of gastrointestinal and cardiovascular risk. Out of NSH, naproxen is the safest when it comes to cardiovascular risk with less severe risk, but it has a more GI side effect profile. Aceclofenac and etrocoxib, there are less GI side effects, but in the government sector, we only have diclofenac and celecoxib. Naproxen is available in a smaller dose, that is 250, not the 500, which is the adult dose. On long term, avoid regular NSAIDs, change over to as required or SOS treatment. That is again, in pure rheumatoid arthritis, you may not need NSAIDs at all on long run, but if they have a secondary osteoarthritis, those are the people who need NSAIDs. This is just a important graph from Kelly's textbook of rheumatology, and I just want you all to look at 2 things only: the Tmax, that is of each NSAID, and the half-life. So naproxen would take about 2 to 4 hours to act, and it would last about 12 to 15 hours. And if you take celecoxib, it takes 3 hours to act, but last about 11 hours. Compare it with diclofenac, it would get the Tmax in 1 to 2 hours, quick action, but the half-life would be about 2 hours. When it comes to etrocoxib, it's about 1 hour, and the half-life would be about 22 hours. So depending on your personal preference, you might choose the NSAIDs, I generally tend to give heterocoxib. Why I give heterocoxib is 20 to 2 hours. It's once daily dosing is enough, and the patient compliance is more with a once daily regime. But for rheumatoid arthritis, you may need heterocoxib only for about couple of weeks, and it's a lower dose that you need to use, not the higher doses of 120, 90, 60 is more than enough. And another point is, again, the meloxicam, the maximum dose you can give is 15 milligram, and it would be, the action would come about in 5 to 6 hours, but it's the duration, it's long lasting, 20 minutes, so 20 hours and so. Now, the most important part from rheumatologist point of view is not the steroids or NSAIDs, it's the rheumatoid DMARDs. So when it comes to rheumatologist armory, we have a sort of vast armory of with different weapons. We have the conventional DMARDs, which include hydroxychloroquine, leflunomide, methotrexate, and sulfasalazine. And the newer targeted synthetic DMARDs, that is baricitinib, tofacitinib, and the biological DMARDs, TNF alpha inhibitors, B20 cell CD20 inhibitors, rituximab, and IL-6 inhibitors. Those are the tocilizumab and cerulumab. And also abatacept, which is a T cell co-stimulator, and that is not available in Sri Lankan setting. But whatever the weapon you have, you need to use these weapons at the right context. It's very simple, like this. If you see an unarmed soldier who's not firing, you should not go and fire at him. It's like this. You have joint pains. Let's say he has a positive rheumatoid factor, but these joint pains are not inflammatory. So don't go and just leave it. That is the concept. So you don't need to start on DMARDs only because he has a positive rheumatoid factor. You need to start treatment only if the patient has inflammatory joint symptoms and so on. And the second point is, for a Red Indian War, we should not be using the heaviest weapon or the best weapon. Likewise, in rheumatoid arthritis or inflammatory arthritis, if the disease activity is low, there is no joint erosions, if there are no extraarticular manifestation, a simple hydroxychloroquine or a low dose of methotrexate or sulfasalazine is enough. Then, if it is a Gulf War, a Persian Gulf War, the hydroxychloroquine or methotrexate alone may not do the job. You might need a stronger weapon like a biologic DMARD. Some of the important side effects of DMARDs, as you all know, methotrexate, the commonest is the nausea and vomiting, not the cytopenias or transaminitis. Pneumonitis is very rare. Leflunomide, hypertension is common. Sulfasalazine, the most important thing is you need to advise the patient of Stevens-Johnson syndrome. Hydroxychloroquine, there's HCQ windows sort of retinopathy, but today I have never seen a HCQ induced retinopathy. Then biologics, rituximab increases the chances of hepatitis B reactivation and increases the risk of infection. And the TNF inhibitors increase the TB reactivation risk. The problem with tocilizumab is you more often see neutropenias, and there's clinically significant lipid metabolism derangements. I just wanted to highlight this point because I thought this is appropriate era to talk about the cost as well. what we need to know is how much we spend on DMARDs. So all the guidelines would say start on methotrexate because of the evidence base or the evidence which is available. And it is in fact true when it comes to the cost as well, because if we prescribe a 20 milligram weekly methotrexate, it would cost about only 480 rupees. Whereas if we start on sulfasalazine prescriptions, it would cost about 2,400 per month. If you go for the full dose of leflunomide, it would cost about 20 milligram tablet to cost about 108 rupees. The total cost could be about 3,250 per month. And again, another point is hydroxychloroquine is very expensive. If we give 200 milligram daily dose, it would be about 1,500. And if goes to a BD dose, it would be 3,000. So it's very important that if we are giving a private prescription or even for the government health budget, if we are starting on leflunomide and hydroxychloroquine, there is a added burden on the government budget. So always it's important to start on methotrexate if there are no contraindications. And never Janus kinase inhibitors, 5 milligram BT, the optimal dose would cost about 18,000 per month. These are the monoclonal antibodies available in Sri Lanka. We have the luxury of prescribing them, but we need to prescribe them in the right context, because the government is allocating 15 lakhs per a patient per year for biologics. But we should know to whom we need to request them and in which context. This is the presentation. This was the analysis I did in 2017 for the CCP Young Physician Forum. This is how much it would cost if we prescribe one of these biologics. This is in 2017, and now this is totally not possibly. I haven't gone through the recent prices. This may be much more than this now with the dollar, the current dollar rate. So if we prescribe infliximab, total annual cost would be 13 million. Sorry, 1.3 million. For golimumab, which is a TNF alpha, it would be at least 1.5 million in 2017. So I'll come back to this cost analysis. Why I pointed this is, when it comes to the primary care, we need to refer the patients early and start off the methotrexate and build up the confidence in the patient on those initial treatments. So this is, I'm not going to go into the guideline. What it says is, you start off methotrexate if there is no contraindication. If your target is not achieved, you might add sulfasalazine or leflunomide. After 6 months, if the target still not achieved, you might try biologics of Janus kinase inhibitors. Third phase is, if you are not still achieving the control with biologics, you can switch over the medications. The final section of this presentation, I'll just go through a case scenario. So this is a patient who had come to my clinic, and he is a diagnosed patient with rheumatoid arthritis for 1 year, was referred through the and previously managed in a local hospital, but defaulted follow-up after 1 month of treatment. Later sought cure from Ayurveda, nevertheless had unsatisfactory results. And on presentation, he had active synovitis with trace inflammatory markers. I was about to commence methotrexate, and this is what he said. No, he refused them, saying weekly tablets do not work for him. The reasons given was, I tried them for 1 month in the past. There was no response at all. I could not tolerate 6 tablets. It's a cancer medication, and injections are not good. When I was trying to inject the knees, he came up with this explanation, these explanations. So if you carefully look at this, there's a the problem is from our management, the prescribers. The fault is with the prescriber here, because I tried them in the past for 1 month. You need to adequately explain to the patient that 1 month methotrexate treatment would not give the results. That is why you should be starting him on a steroid. Because obviously, if you don't start on a steroid or a NSAID, the patient might not feel the benefit. And the steroid duration should be more than 2 weeks, and you can continue the steroids for more than 3 months if required. And the golden rules in starting DMARDs is go slow. Make the patient to believe that the medications are working. Give an adequate dose of initial dose of steroid, then slowly tail it off. Then gradually, if the patient is having so many constitutional symptoms at the beginning, I generally would not prescribe methotrexate right at the first consultation. I would ask him to come back in 2 weeks' time with a good dose of steroid. Then he feels that the joint pains have gone off. Then he would be happy to decide on another medication. The second thing is gradually introduce DMARDs. Start off with methotrexate 10 milligram, that is 4 tablets, and slowly go on, escalate. Explain the common side effects, and it's well known that if you explain the common side effects, the compliance would be more. Anticipate and deal with the side effects. There would be GI intolerance with methotrexate. For that, we can increase the folic acid frequency. In UK setup, people say that ingesting with Coca-Cola would increase the reduces the nausea and vomiting associated with methotrexate. And in other countries, and in Sri Lanka as well, we have the facility of going for subcutaneous methotrexate if there's GI intolerance. And the most important thing is give frequent initial appointments for inflammatory arthritis patients. See them frequently and escalate the medication slowly. If somebody tells you that, always, the second point is try your best to continue with methotrexate and establish what the maximum tolerable dose of methotrexate is. If the patient cannot tolerate 7 tablets, you better ask what the maximum dose you can tolerate. If it is 5, you continue with 5 and then add on another DMARD rather than taking off methotrexate and adding on another DMARD. So continue with highest tolerable dose of or maximum tolerable of methotrexate. Always clarify what is meant by intolerance to methotrexate. And do not make more than one change at a time. Because if things go wrong, you'll have to come back to the square one and start again from the very beginning. The other cardinal thing is, if something is not broken, do not go and fix it. When you are treating, if the ESR is high, if there are no joint symptoms, don't go on escalating the treatment to bring the ESR down. So if the joint symptoms are perfectly all right, you can do ultrasound scan and see whether there's active synovitis. If the things are very much nice, you can leave the things alone. This approach would prevent unnecessary DMARD escalation, as I mentioned. So these people would not go on for biologics if we go on in this pathway, because we are preventing the joint deformities and so on. It would save millions when it comes to the health budget. Just a word about hydroxychloroquine. Some people prescribe it very often, but the dose is actually 5 milligram per kg per week. That's not a fixed dose. If the patient is 60 kilograms, the dose would be 300 into 7, that is 2100 per week. So how are you going to give 2000 milligrams is, you would give 200 milligram BD 5 days, that is to the weekdays only, and give a drug holiday on the weekend. And it's not 200 milligram BD for 7 days, because this is where you would be seeing the increase in the risk of retinopathy. And it's not an alternative NSAIDs, always used rationally. And some points about methotrexate. In the constraint of time, I would just brief on this. And it's believed that methotrexate increases infections, risk of infections, but actually methotrexate increases, but not only methotrexate, RA or rheumatoid patients are at a greater risk of infections than non-RA patients. So rheumatoid itself is a sort of a risk factor for increased risk of infections. And just this talk about methotrexate-induced ILD. What you mainly find with methotrexate is not the ILD, where you will be seeing the pneumonitis at the early phase of commencement of methotrexate. And pancytopenias are common with methotrexate, so regular blood monitoring is needed. And I need to finish off this presentation, I need to make this point. This is a nightmare for a rheumatologist. Sometimes in your practice or the hospital, the patient comes with telling that they have an inflammatory joint symptoms in the past, but when you examine, they absolutely, the examination is normal. The now question comes into that we come across is, are we dealing with an early arthritis, or has somebody treated with NSAIDs or possibly steroids? And it's a difficult situation, because at that point what we all do is take off all the medications and start let the patient stay without medication for a couple of weeks, and once the inflammatory symptoms develop, then only we decide on the treatment. So take a message from this presentation is, if you come across patients with inflammatory sounding joint symptoms, please do refer early to a rheumatologist or specialist physician, ideally without treating with steroids and NSAIDs, because all these joint symptoms, we all struggle to differentiate or come to a conclusion if you mask the things with steroids and NSAIDs. If you start on an NSAID or a steroid, please disclose that. Treatment with DMARDs can be commenced based on inflammatory nature of the symptoms without waiting till the classification criteria is fulfilled. And the last thing, with early DMARDs, initiation will prevent long-term joint damage or deformities. To finish off, I was practicing rheumatology since 2015 as a senior. I started in 2015 as senior registrar, but I was over the moon when seeing this, because over the last 7 years, I have never seen a referral like this, and it came from Mathale OPD. I don't know the medical officer who had done this. This is what we were talking about all this time. If you come with the inflammatory, if you have the suspicion of inflammatory joint disease, do refer early. I'm very pleased with him, because he has also mentioned it early, early appointment, sort of early date, please. And on the next day itself, this patient was referred to the rheumatology clinic. So this is what we expect from a medical officer who's in the OPD system, because you need to pick up the patients who needs early reference. So obviously, we should give a gold medal to this medical officer. So to finish it off, hopefully I have demystified some of the dilemmas or diagnostic problems, and I would also like to thank the President and the Council of MCS for giving me this opportunity, and also Indigo Remedies Pharmaceuticals or Hemas Pharmaceuticals for sponsoring this lecture. Thank you very much. I would like to answer a few questions if there are any. Not really. Let's say there are instances you would be thinking of biologics, pregnant patients. If there are contraindications, you would only be dealing with sulfasalazine. But in that case, you can use cetrasolumab pegol, which is not available in Sri Lanka, which is a TNF alpha inhibitor. And generally, you always go for stepwise manner. That is, start the DMARD and then go for the biologic DMARD. Synthetic DMARDs first, try that, biologic DMARDs later. If you have a struggle in controlling, give a good dose of prednisolone or steroids. You might need, in very rarely in inflammatory arthritis, you might need IV methyl prednisolone. It's about 60%. It's not that sensitive or specific, I would say. Sorry? That's a good question. In osteoarthritis, the first of all, one who does what is the place of steroids. I generally give small dose of steroids for 10 days. That is not for osteoarthritis. But in osteoarthritis, if you palpate the joint, there would be a surrounding bursitis. Most of the time, pes-sensorin, semitendinous bursa, which is involved, and those people respond to steroids. And the second thing is, there's a component called inflammatory osteoarthritis. The patients comes with, they have negative rheumatoid factor, more or less marginally elevated ESR and inflammatory joint symptoms. Those people, I would give them a course of steroids, good dose of steroids. And if responsible, you start on hydroxychloroquine. And otherwise, some of the laboratory data would say that there is a small molecule activation, cytokine activation, and so on. But that is not clinically, what is the wording for that? That response is not clinically significant. So generally in osteoarthritis, no DMARD, only two things have shown to be efficacious. Number one, weight reduction. Number two, quadriceps tension. And there might be a place for PRP or platelet-rich plasma. Orthopedic guidelines would favor that, but rheumatologic guidelines does not favor for PRP. Again, PRP should be given in early disease, not the late disease. And if things are not responding, early treatment. But there is no place for DMARD in hospital. There's an entity called burnt out rheumatoid arthritis. So that is if the disease is going on for some time and the disease itself wants out, and you don't need to treat, only treat with joint symptom, because one thing is you can, if you are in a dilemma, you can establish these joint disease activity using ultrasound scan. If there is sign of this with increased power Doppler signals that that says the joints are active, in that case you can decide on DMARDs. Generally, if clinically burnt out, just NSAIDs on SOS basis. We can, if ultrasound facilities are not available. Now I'm talking about this setup with a to expert musculoskeletal radiologists. But if somebody is not competent in MSK radiology, what I do is give a good dose of steroids. If symptoms response with steroids alone, based on that, I start on DMARS. That is what we mostly practice. Sorry. Yes. Yes, there's a benefit. Now, this is where, yes, no. For knees, we can go up, if it is rheumatoid or what, osteoarthritis, its dose is 80 milligram. Every 6 monthly, you can go. That is what, what I usually do is I would give a intraarticular steroid, and if it does not last for 1 month, I would not repeat, because injection for 1 month is not beneficial. If somebody has gets a benefit for more than 6 months or 4 months, I would repeat it after 6 months. Yes. Yes, it's yes. Yes, PRP theoretically helps in the proliferation, whereas steroids, even if you give to a sort of not to a subcutaneous what we call soft tissue rheumatism, there is a risk of ligament and tendon. What is the wording for that? Thinning out, or yes, that again happens in the cartilage as well. So that's why you don't give frequent steroids, sparing. So 6 weeks, leave 6 weeks. Yeah, that's it. 6 months. Yes. 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 As sulfasalazine is so that's why it always say methotrexate first, and if there are contraindications, use sulfasalazine, particularly in patients with pregnancy, fertility issues, and so on. The other thing is sulfasalazine is more effective in case if you examine the joint, there may be tenosynovitis. In tendon involvement, sulfasalazine is more effective. And also in Achilles tendon involvement and enthesitis, sulfasalazine is more effective. In that case, you use, but in erosive disease, even with the guidelines, I'll just go through this guideline. So the in the absence of what it says is here, there are 2 arms. One is if there are once you establish the diagnosis of rheumatoid arthritis, if there are 4 prognostic factors. 4 prognostic factors are extraarticular manifestations, high disease activity, bone erosions. Start methotrexate. If there are no 4 prognostic factors, that is what I meant. You can go on to the disease activity is low, no erosions, and so on. Can try hydroxychloroquine and sulfasalazine. But if the things are not working, you need to escalate into methotrexate and rest of the things. But Again, we might not be able to follow on the guideline. Generally, guideline would say after 6 weeks, if the disease is not 6 months, if the disease is not under control, to go for a biologic. We generally wait for at least 1 or 2 years. We try to escalate. We go for technically incorrect combinations. We combine methotrexate and leflunomide, which is hardly practiced in UK and the other setup. So methotrexate and leflunomide, because it increases the transaminitis risk. So we take the risk and combine, because that combination would prevent us from going into a biologics. So one factor is we are dealing with the cost as well. So we generally can't just escalate according to the guidelines. We just want the unconventional. We try unconventional combinations and try. Yes. 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 Yes, but what I generally do is, if now let's say after 3 months, if I feel that this patient needs a higher dose escalation or going into a higher disease modifying treatment, I would stop. If the patient is at methotrexate 20, I would bring it down to 15 and then put the methotrexate to 10, 20 and increase the folic acid frequency to 3 times a day. That combinations had helped me to overcome the transaminitis. Yes, because this would prevent us from going to biologics or Janus kinase inhibitors. Yes. From patient's point of view, it might not be the ideal, but health sector point of view, that may be the thing. Because yes, that's what I was. Sorry, I didn't go through that. There is some dilemma about that, whether the methotrexate causes lung fibrosis. The evidence for that comes from, we treat psoriatic arthritis, but we don't see, even though we use methotrexate 20s, in psoriatic arthritis, we might need 25, that is 10 tablets. We don't see much of lung fibrosis in psoriatic arthritis. So that is a point to say, is methotrexate causing lung fibrosis as we think? So but in rheumatoids, it causes, we come across lung fibrosis. That is possibly because of the rheumatoid disease process rather than methotrexate. Yes. 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 In that case, we can change over to rituximab, where it works for lung as well as joints. The other thing is with rheumatoid arthritis, what you see is pneumonitis. with the commencement of the methotrexate, you would be seeing the lung involvement within a couple of months. And it's in the early phase rather than in the later phase.
First of all, apologies for the inconvenience. I truly appreciate Dr. Amal, consultant rheumatologist, and your time spent today for the lecture. And I express my gratitude for the excellent lecture, and it was very informative and practice guidance point of view. And thank you very much, sir, for the on behalf of Madrid Filter Society. And I'm really grateful for you all for the rapid attention you all made throughout the lecture. Thank you very much for staying for long. And I'm confident that you all have taken most of the thing out of this lecture. Thank you very much, Dr. Amal, for the great presentation. And finally, I would like to express my thanks on behalf of Madrid Filter Society for Dr. Amal again for organizing the sponsorship and taking the meal from Candy to here. Thank you again. And two notices. One is Dr. Amal is very keen on academic scenario, and he's willing to support you for the research point of view and academic purposes. So we are planning to have a platform. So your suggestions are warmly welcome, and we'll let you know soon when it started. And a second one is from Art Circle, we are conducting the Vesak Batigi on 26th from 12 to 2. So I'm taking this opportunity to invite you all for the as audience and the singers. So lunch is ready. You can take it with you and have a good day. Thank you.